All right, well, welcome everyone, and thank you very much for joining us for the online event, A Next Generation Approach to Spinal Cord Stimulation, hosted with Dr. Paul Lynch. My name is Brianna Hunt, and I am a member of Nevro's team here in California. We are hosting today's presentation and are the manufacturer of a chronic pain treatment option called HF10 Spinal Cord Stimulation, which will be a part of today's discussion. Today, Dr. Lynch will provide an introduction to HF10 spinal cord stimulation and highlight some of the differences and benefits relative to traditional spinal cord stimulation. We will also allow time at the end to answer important questions from you, our audience. You can submit questions at any time by clicking the question icon in the bottom of the Zoom window. All general questions related to the presentation and procedures discussed are encouraged and welcomed. We will address as many questions as possible at the end of the presentation. For questions specific to your unique history, we recommend you speak with a physician personally for medical advice. As I mentioned, Nevro is the sponsor of this talk and also the manufacturer of HF10. We are a passionate group of people exclusively focused on developing innovative solutions for chronic pain. Stephen, next slide. Worldwide, over 75,000 patients have now been treated with HF10. Stephen, next slide. And with that, I am very excited to introduce Dr. Lynch, our expert speaker for the day. Dr. Lynch is located in Scottsdale, Arizona, and dedicates his life to the eradication of pain for his patients. He is double board certified and fellowship trained in interventional pain, and studied at Beth Israel Medical Center in New York City, New York University, and Texas Tech University. Finally, he's the co-founder of several national pain management institutions, including Pain Doctor Inc., Arizona Pain, Texas Pain, Holistic Pain, and Boost Medical. Dr. Lynch, thank you so much for your contributions today. And now I will turn it over to you.
Thanks, Brianna. I really appreciate you having me on, and I appreciate all the wonderful employees over at Nevro. Nevro is such an incredible technology-driven healthcare company that I've been just super blessed to work with for the last 5 years. And I've personally seen you change lives around the world, and especially in our own practice in Arizona. So thank you guys for putting this on and for caring about our patients.
You're very welcome. Thank you for being here with us today.
Next slide. So for everyone who joined in to hear about spinal cord stimulation today, I just want to start off by saying I'm Paul Lynch. She introduced me. I've been an interventional pain physician for the last 14 years. My first job was at Mayo Clinic in Scottsdale, Arizona. And I started my own practice called Arizona Pain, and we're located in the Phoenix area in Arizona as well. I've been given the opportunity to manage clinics all around the country. So I've managed pain clinics in 17 states now, and I've seen lots of people with pain. I've seen lots of pain physicians and their approach to pain. And I will tell you that unequivocally, one of my favorite therapies for patients is spinal cord stimulation. When I say it's my favorite, what I mean by that is I get the very best bang for my buck, the biggest increase in pain relief for patients. And I already saw 10 or 12 questions coming through, which I really appreciate. Keep your all's questions coming. A lot of the questions were about how much does this cost and is it covered by insurance? And the answer is yes, most insurance cover it. Medicare covers this procedure, and the costs are typically pretty low for you. So for the amount of pain relief that we're able to give to patients, the fact that it's covered by most insurances is such a blessing for us. So what are we going to talk about today? Number one, when to consider upgrading your spinal cord stim device. Some of you guys joined and you already have a stimulator. And so you're thinking maybe it's not working as well. Maybe you've talked to your doc about taking it out. What I'm going to talk to you about today is maybe it's time to look at different technology. It's kind of like our phones. I've got the iPhone 25 or whatever the newest generation is. And I hate to admit it, but I probably upgrade it every year, every 2 years. Some of you have had the same stimulator for 5 or 10 years and you're thinking maybe it doesn't work as well. Well, it might be time to talk to your doctor about the new technology. So we're going to talk about that. We're going to talk a little bit about limitations of traditional spinal cord stimulation and whether HF10 therapy from Nevro might work better for you. We're going to talk about studies that demonstrate that HF10 works, and not just works, but it works long-term, like 2 years or more. And then we're going to talk a little bit about if you were going to upgrade your device, what it would be like if you were going through a replacement procedure to take your existing device and switch it out to the new one. And then at the end, we're going to take lots of questions. We're going to hang around till 4. So you can't overwhelm us. You can play stump the doctor and ask me any questions you want, and I'll try to answer at the end. So I can already see the questions populating at the bottom. That makes me really happy. I appreciate that you guys are so engaged. So feel free to send any questions. So that's going to be our agenda. Next slide. So when should you consider upgrading your spinal cord stimulator device? Well, I did a video with this actually with Nevro this week, and we were talking about when it would make sense. And we came down to 3 main reasons that I've been teaching. Number 1 is you have a current stimulator and you're just not happy with it anymore. And so it might be time to upgrade. Number 2, maybe you had a stimulator in the past and it stopped working. Maybe you got it taken out. Maybe you still have electrodes in. It might be time to look at the new generation technology and still see if it works for you. Or 3, your non-rechargeable device is approaching the end of its battery life and you're thinking about upgrading. This could be a time to do it when you need to switch out the battery. Next slide. What's the history of spinal cord stimulation, and what are the limitations of traditional stim? So some of you guys may know this if you have a stimulator, but spinal cord stimulation was first invented over 50 years ago, way back in 1967. And at that time, they had all sorts of theories about how it worked, and they called it the gate control theory of pain. And what it came down to was the electrode was stimulating what's called the dorsal column. And it's a part of your spine that is responsible for proprioception. So if you had a traditional spinal cord stimulator, what you'll probably remember or know is it causes a paresthesia-like feeling in your legs, like a ticklish feeling, almost like a TENS unit. And that paresthesia, what it does is it distracts your brain from pain. And more scientifically, it actually blocks the receptors from firing, but in an indirect fashion. So you're actually stimulating the dorsal column that indirectly stimulates where the pain signals are going to the brain. That's all changed with new stimulation. I'm going to get to that in just a second. There's some limitations with traditional spinal cord stimulation. Number 1, some patients don't like that paresthesia feeling. And over time, it kind of starts to drive them crazy. And so a lot of the companies have started doing research on how could they provide the same kind of relief, but without that aggravating paresthesia. Number 2, the traditional spinal cord stimulation just honestly doesn't work very well for back pain. It works really good for leg pain, but not for back pain. Number 3, another limitation is even in our best studies, we only showed about 50% of patients got 50% relief with spinal cord stimulation. And as I teach about HF10, what you'll find out is that with the new technology, it's more like 80% of patients are getting 80% relief. That's so exciting for us when we see patients get 80% pain relief. It's like giving them their life back. There's a few other limitations of spinal cord stimulation that I want to mention. One is a lot of times you have to turn it off when you go to sleep or when you drive. You can't get an MRI. So there's all sorts of limitations. And in fact, HF10 from Nevro was invented in part to address a lot of these limitations that I'm talking about on this slide. Next slide. So what did HF10 do? When they came to market, they wanted to make sure you could get MRIs. And so Nevro is conditionally approved for full body MRI. So if you have an old device, you may have issues with imaging, but with the Nevro HF10 device, you can get a full body MRI. HF10 was designed to provide more pain relief. So we talked about traditional stim gave 50% relief or 50%. The data from the Senza trial, which was one of the largest randomized double-blind placebo-controlled trials ever done on spinal cord stimulation, HF10 showed that about 80% of patients got 80% pain relief. And so HF10 was directly invented to try to get better pain relief. HF10 was approved by the FDA in 2015, and the trial showed that long-term that 76% of patients are still responders at 24 months. And so 24 months may not sound like a long time, but I'll tell you as a doctor who deals with patients, if you can give someone 76% pain relief for 2 years, that's essentially giving them their life back. It's a huge deal. HF10 has been demonstrated to show significantly better and longer lasting pain relief from back pain. I can remember when I first started teaching in spinal cord stimulation way back in 2007, I was trying to do a spinal cord stimulator for a patient, and it was rejected. And the insurance said, in their experience, spinal cord stimulation only worked for the back around 5% of the time. That's what they said back to me. And at that time, there was some truth to that. That was a little bit overstated, but I remember them saying only 5% of the time does it work for back pain. Well, with HF10, their data for the back is just as good for the leg. So over 70% of the patients responded just with back pain, which is so exciting for some of our patients. Next slide. So how is HF10 different? And I've kind of touched on this a little bit, but traditional stem, or let's just start with HF10. It was designated as superior by the FDA compared to other SCS systems. They said very specifically that this worked better. They got a indication for superior outcomes. There's significant relief with HF10 for back and leg pain. And I know most of the patients that come in to see me, they have back pain and leg pain, not just leg pain. You can leave it on 24/7. There's no driving restrictions. There's no sleep restrictions. So that's a big win. There's no tingling paresthesia sensation. In fact, it works in a very different place. It actually directly inhibits the way the nerve is firing to the brain. It's called the dorsal horn. It's where the pain sensation travels along the electrical circuit to the brain. And HF10 works directly on the dorsal horn. So it's working very different. That doesn't cause that paresthesia tingling feeling that some patients find unpleasant. And it requires limited to no daily remote usage, which is pretty cool. You can kind of set it and forget it. Your rep will work with you from the company to put some cycles in the background. They may cycle it between tonic and HF10, or maybe HF10 and off, or they can even try burst therapy, but they can usually just set it and forget it. You don't have to fool with your remotes a lot, which is nice. And then the last thing is the battery lasts a whole lot longer with these non-rechargeable units. So the battery is designed to last 10 plus years. So that's a real big win for some of our patients that don't want to go back in and get the battery replaced every 2 or 3 years. Next slide. So I talked to you a little bit about the leg and back pain relief that you get with HF10. I want to go through some of this data. So there was a large randomized controlled trial done by HF10 on HF10. And the goal was to compare HF10 therapy to traditional spinal cord stimulation therapy for back and leg pain. And what we found was that HF10 provided more relief than traditional spinal cord stimulation, and not just for leg pain, but for back pain as well. So I want to just show you this data here. This chart's a little bit hard to look at, but what it's showing is the black line is how much pain the patients were in the traditional spinal cord stimulation group. And what it showed is their pain started around 8, but by 24 months, their pain on the far right of this was almost 5. And anyone who suffers with pain, 5 out of 10 pain is still pretty bad. You're thinking about that all day long. It's on your mind. It's limiting your ability to do stuff. But if you look at the blue line, that's the HF10 therapy. And what you see is it's less than 2.5. And that might not seem like a huge deal, the difference between 5 and 2.5, but it's a massive deal. If a patient tells me they have 2.4 pain or 2 out of 10 pain, we're generally saying, you know what, we don't need to do any more procedures. We don't really need to take these meds all day. It's a slight aggravation, but you're not crying in pain all day. And so what we showed with HF10, and this is just for back, but the pain went from about 8 out of 10 down to close to 2 out of 10, and that we continue to have that response for 2 years. So that's a really, really big deal. And if you look at the responder rate, at 2 years, people experienced more pain relief with HF10. For the back, it was 77% of patients that were at least 50% pain relief versus 49% in the spinal cord stimulation traditional group. And for leg pain, it was 73% versus 49%. If you noticed, it's not a real big difference, but the back pain actually worked even better with HF10. So it's totally flipping the paradigm that spinal cord stimulation is best just for the legs. With HF10, there was a better response in the back group. Next slide. So people achieve long-term relief with HF10 in the real world as well. So sometimes doctors do these big studies and they show something works, and then in the real world, maybe it doesn't work quite as well. So HF10 and Nevro set out to see if that was true. They looked at 1,660 patients who got a HF10 spinal cord stimulators, and they looked out over 2 years. And 74% of those patients had at least 50% relief 2 years later. And so this real world trial showed that it worked just as well as their big randomized double-blind controlled trial that they got approval with. So that was really exciting for a lot of us pain doctors. They wanted to make sure that our patients were actually getting relief in our practice. And I'll show you some of my data in a minute. We've seen the same thing in my own practice. Most participants reported improvements across the board, including 72% said that they had improvement in their function. 68% said they had improvement in their sleep. And over 90% had an increase in quality of life. What a cool statistic. Next slide. So this is just looking at the different companies. Right now, there's 4 main companies that do spinal cord stimulation. And what you see with Nevro, the Omnia unit, Omnia device on the far left, is they can do HF10 high frequency stimulation. They're the only one that's approved for that through the FDA. They can also do HF10 and pair it with low frequency. So when I talk about the representative from the company can work with you and make a program that works, they may cycle HF10 with classic stimulation. Maybe you did like that paresthesia, but you only like it for a few hours a day and then you want that to go away. They can actually design the device to do pretty much whatever you want. So it can do HF10 high frequency, it can do low frequency normal spinal cord stimulation, it can even do burst stimulation, which is one of the waveforms that's become really popular over the last few years. Next slide. So let's say you agree with what I'm saying. You're like, you know what? I think it's time for me to get a new spinal cord stimulator. What's the process? Well, number one, you need to talk to your pain doc. Just me telling you this nice talk about it's not enough. You need to go talk to your doc and see if they agree. Tell them what you learned today. Do your own research and see if you think it's the right thing, and then present it to your doctor and see if they think it's a good idea. Number two, they may want to do a trial with you. So the doctor may say, hey, you know, you've had this traditional stimulator in, we might want to do a trial with Nevro, with the HF10 leads, just to make sure it's going to work. Sometimes they don't. Sometimes if you're like at the end of flipping out your battery, they might just put in the new HF10 device, and that would be appropriate if you got good relief in the past from stim. It'd be okay to upgrade in that situation, but they might want to trial it. So talk to your doc and see what they'd like to do. And then the third step is it's time to go to the OR and receive your new upgraded device. That's actually a lot easier than you think. I do these procedures a lot, and it's a very short procedure, just usually one incision. We identify the battery, we disconnect it with a screw and screw in the new one and put it back in. It's a very short procedure for an experienced doctor. And so that part's pretty easy. And then I'm not sure if I talk about insurance on the next slide, but I'll just tell you that most insurance companies, if they paid for the simulator the first time, they also are signing up to pay for replacements. And so most insurances won't give you too much pressure on flipping out the battery. Next slide. So common questions I get. I'm actually going to answer some of the questions we're expecting. By the way, I'm looking at the bottom. We have 30 questions that have already come in. So that makes me happy. It seems like you guys are very engaged, and I'm excited to answer some of your questions. But I want to answer a couple questions that we expect to get. So number one, I've tried everything else. Why should I try this? What I tell patients is, in all the literature in pain management, this is one of the most evidence-based things that we have. 80% of patients get 80% relief. And we can do a trial before we do it. I tell patients, you can try it before you buy it. And so the trial, many patients that are on this call probably had an epidural injection. You know, the idea of an epidural injection is we go in the epidural space and we put medication. With HF10, a trial, we would go in the epidural space, and instead of leaving medication, we thread an electrode. So it's not a huge difference of stuff you've tried before. During the trial, we tape it to your back and you walk around for 3 to 7 days and see if you get pain relief. And if you do, if you're in that group that gets 80% pain relief, then you're really going to want to go toward the next step. And the next step's not that hard either. It's a permanent implant. It usually takes less than an hour. It's not big surgery. So the answer on you've tried everything else, why should you try this? You should try it because it's evidence-based. It works really, really well, and it's low risk for patients. The next question I want to answer is, do all spinal cord stimulators deliver the same waveforms in all frequency? No. Nevro is the only one that has a patent on high frequency stimulation. So they're the only one that can do HF10, and they're the only one that's using this mechanism of action where it's stimulating the dorsal horn directly, which we believe leads to better pain relief. Next slide. What is the difference between rechargeable and non-rechargeable batteries? That's a great question. A lot of my patients have been asking me about this lately. So there's been trends in the industry, and for a while we went to non-rechargeable batteries because we thought we could just set it and forget it and you'd have to fool with it. What we're finding is they're running out a lot faster, especially as we're learning that higher energy waveforms might lead to better pain relief. They're just dying faster. It's kind of like, once again, our phones, now that we're searching the internet, checking email, playing on TikTok. I'm a big TikToker. You know, we're killing our batteries faster, and the iPhone people have to make bigger and better and longer lasting batteries. It's kind of the same thing with the stimulators. If we want these higher energy requiring waveforms, then we need batteries that last longer. And the best way to do that is to have a rechargeable battery. Now, some patients don't want a rechargeable battery because they have to fool with it. And so we can do a non-rechargeable, but I'm recommending to most of my patients just to get a rechargeable battery so that they can take advantage of these higher frequencies and higher energy waveforms. Number two, does insurance cover battery replacements? I kind of touched on that earlier. If you already had a stimulator and it was already approved, then battery replacements will be paid for. What we're finding with a lot of these non-rechargeable batteries is they're running out in 2 to 3 years anyways. And so it's a good time to talk to your doc about upgrading it to the new technology. Next slide. So I just want to quickly touch on my own data, my own practice. So there's 3 levels of data I want to talk about today. The randomized controlled trial that showed about 80% of patients got 80% relief. And then they did a 2-year trial of patients in the real world, and they showed 76% still had good pain relief at 2 years. And in my own practice, I matched that number, 76% responder rate of at least 50% pain relief. So I can tell you, I can vouch for this technology. And this was around 200 patients in our practice over 6 years. And so we've had, and that's not just me, that's all of our doctors here in Arizona, but over around 200 patients, to have 76% of them still doing well long-term. We're really happy with that number. We also showed about 34% of patients decreased their medication use, which is a really big deal. 67% said they improved their function, and 62% improved their sleep. So we've had wonderful success with HF10 therapy in our patients. Next slide. I want to finish with just talking about one of our own patients. He gave us permission to use his face and his name and his story, but Richard was hurt in an accident while working, and he was always constantly in pain. He couldn't spend time with his family the way he wanted. He couldn't hold his kids anymore. And he came to us, and this is Dr. McJunkin, my best friend and business partner in Arizona. Interestingly, Tori McJunkin, we went to college together too. So we've been friends for 26 years. And Richard came to Dr. McJunkin, told him a story, and Dr. McJunkin decided he wanted to try HF10 therapy. And it totally changed Richard's life. Matter of fact, this is a quote from him. He said, HF10 has been a life changer for me. I am hiking, climbing ropes, and running around with my 2 girls again, who are thrilled to have their dad back. What a wonderful message. And I want to end with that and turn it back over to Brianna. Next slide. To talk about next steps, and then I'll be here to take any questions in a minute.
Wonderful. Well, thank you so much, Dr. Lynch, for sharing your experience and knowledge with us. And we look forward to getting into the question portion of this. Just to let everybody know before we jump into that, what the next steps will be. Everyone will be receiving an email with a link to this recording of this presentation, because we know there's a tremendous amount of information and data being thrown at you here, and we don't expect you to remember everything on the fly. So don't worry, we will be sending this out within 24 hours so that you can have this presentation to review or share with a family member or loved one, so that you can watch it together if there's questions that you feel like you didn't get answered today. Also, a patient coach will be reaching out to you by email or phone to offer you the opportunity to have a conversation if you requested one on the landing page when you signed up. So there were some of you who provided your phone number, and so somebody will be reaching out to you in the next several days to have that conversation. If you didn't provide your information at that time, but you are still interested with speaking to a patient coach and a local care team member, you can also give them a call at 1-800-387-2381. So if you did give them their phone number, this number will show up on your phone. So please consider saving this number to avoid confusion with spam. We all know how many 1-800 numbers we get, and that very rarely are the ones that we requested. So just a tip there, so you make sure to not miss it, is you can put this number in your phone and save it as HF10, and that way you'll be sure to not miss the call. You can also learn more about HF10 and use our physician finder to find a physician in your local area by visiting hf10.com. So all the information that we've shared today and many more, including more patient stories, are available at hf10.com. So if you want to do more research and you enjoy like reading content versus just listening to it, there's a lot more information for you to gather there. And then finally, just call out, with COVID, there's been new regulations around telehealth, and that telehealth is available for many patients to have a consultation with a provider. So you can schedule a telehealth visit and let your provider know you're interested in HF10. That's just something in the last year that's become made much more accessible. So we know some people may not be wanting to go into a practice for various reasons, but telehealth is a great alternative to at least have a conversation and see if you might be an appropriate candidate. Next slide, please. All right, now on to the lightning round, as we like to call it. We have an amazing 43 questions in the queue, so we'll try to knock out as many of these as possible. Looks like you all have found the Q&A at the bottom of your screen that we've highlighted here. So if you happen to not see it before, please go ahead and put your questions in there, and we're going to do our best to answer all the questions over the next 30 minutes. We will be wrapping up at 4 o'clock. And so if we haven't answered your question, we'll try to get to you in the post-event email. But with that, I'm going to start the lightning round and start knocking out some of these questions. So, all right, Dr. Lynch, you ready?
I'm ready to go. I'm so excited with all the questions. 44 questions is pretty incredible, and keep them coming. I think we're going to get through these pretty quickly. So thanks for letting me try to answer all these.
Great. So is this for sciatica problems as well?
For sure. So spinal cord stimulation at the end of the day works really well for any nerve-based pain. We call it neuropathic pain. And so the classic indication, someone that had spine surgery and then they continue to have pain, we call that failed back syndrome. But it's wonderful for other nerve-based pain, and the sciatic nerve's the biggest nerve in the body. And so any patient that has sciatic nerve, which usually derives from the pain from the spine, we can do spinal cord stimulation for that, and it works as well.
Great. What is the benefits of HF10 over injections?
Well, it's a good question. You know, some patients do really well with injections. And so I have patients that get one set of epidurals a year and they do really well, and their pain is down to less than 2 or 3 out of 10 and they're happy. I don't push them towards HF10. But if a patient gets some epidurals or injections and their pain comes back pretty fast and they still have 7 or 8 out of 10 pain and they're suffering, well, then I start pushing them towards more advanced procedures like HF10. The benefit is it's on all the time. It's electrically kind of stimulating exactly where the pain is getting to the brain, and it kind of shuts it down. So it would be like if you were getting an infusion of injections 24 hours a day, 7 days a week.
Got it. Is this device appropriate for arm or hand pain?
Yeah, it is. So it was approved for pain of the trunk and limb. And so the limbs are the legs or the arms, and the trunk is considered anything from the base of the neck or the base of the neck down to the sacrum. And so if you have arm pain, not all providers do cervical spinal cord stimulation. And so you'd want to talk to your provider if they've had training in that. But I've done a lot of cervical in my practice and had wonderful results.
Great. Here's an interesting one. Susan was wondering if this stimulator would connect to leads of a 19-year-old neuromodulation device, which is now Abbott.
I don't know the answer to 19 years ago. Do you guys know the answer to that?
I do not. I know that we do hook up to many devices, but I think in this particular case, I would recommend going in and speaking to your pain provider and seeing. I think it would be a matter of looking at the particular device.
I was going to make the joke that 19 years ago, I was still in elementary school, but I realized that's not true. I was actually in medical school 19 years ago. I'm getting older.
There you go. There you go. So this is regarding the limitations. I want to know if I will be able to bend over from the waist after I have this device.
Oh yeah, for sure. It's such a good question too, because patients think that once they get this and their whole life changes and they can't do anything. I like patients to take it easy for the first 2 to 4 weeks, because I want those electrodes, it sounds scary, but scar in. So it's in the epidural space and you want the fat around it to kind of grab it. And after that, it doesn't move most of the time. Our biggest complication is in fact migration or movement. That only happens about 20% of the time. But if that happens, we have to go back in and reposition it. And so I like patients to give it a couple of weeks to kind of settle in. And then after that, they can act normally. They can bend at the waist. I have patients that are golfers. And so, yeah, you can definitely bend at the waist.
Great. Let's see. So maybe you can talk a little bit more. You mentioned cervical. So this is, can you implant this device at the C3 level? Can you maybe explain the difference between cervical pain and where the device is implanted?
Yeah, so we do this all the time for patients who've had ACDFs. They have a failed neck and they have pain in their neck and their arms. And so we will place the device all the way up to C2, but the electrodes will cover from C2 down to about C6. We'll typically put 2 electrodes in, C2 to C6, and it blocks all that pain that you would feel in your arms and your shoulders and even into your neck. And the way we access the epidural space, every doc's a little different, but I'll typically go at C7 T1 or T1 T2, and then I thread the electrodes up, but they do cover that C3 level.
Got it. Thank you. And just to clarify, HF10 is not indicated for cervical pain, but it is up to the physician's discretion in a particular case if maybe there's some upper arm pain in addition to neck pain. So it's really important to talk to your doctor and get their professional opinion. So.
Thank you.
Yeah, no, of course. Will this eliminate my pain when walking?
I hate to tell people it's going to eliminate, because in my mind, eliminate means 100%. Our findings are that for patients who are well selected, about 80% of pain goes away. Long-term, we know that about 75% of patients have 50% relief. So I don't use the word eliminate, but I would say that depending on your diagnosis, if you have what's called neurogenic claudication, you should talk to your docs and see, is there a mechanical solution? Sometimes pain with walking is caused a severe spinal stenosis, and sometimes surgery can help that, where you open that up and that gives you a relief from neurogenic claudications. Other times you have pain from walking and you've already had surgery and your spine is stable and the doctors say there's nothing else we can do. In that situation, I would expect 80% of the time we could give you 80% relief of that pain.
Great. And you mentioned spinal stenosis, which several people are asking about. So neuropathic pain related to spinal stenosis, do you find, what type of relief do you find in those cases?
Yeah, it just depends. Once again, if your pain is truly caused, I like to use my hands and show you stenosis, squeezing. Stenosis means squeezing. And so we have mild, moderate, and severe stenosis, which is how much you're squeezing those nerves. If you're truly squeezing those nerves where you can only walk 50 or 100 yards and you have to bend over, sometimes a surgical solution is better. But if you have spinal stenosis that either is not a candidate for surgery or has already been operated on multiple times and you're still hurting, now we start to say you have neuropathic pain, then that pain would be better treated with spinal cord stimulation. So long story short, this works very well for spinal stenosis, but I just always try to work the patient up in conjunction with a spine surgeon to make sure that this is the right treatment for them.
Got it. Great. Okay. One of my favorite questions. This patient had prior spinal fusion. Is this an appropriate therapy for them?
Yeah, that's why it was first invented in the 1960s, was patients who had fusions, who had back surgery, who still hurt. And they found that there was actually a really large study done in the 1990s at Johns Hopkins. And they took patients who had spinal fusion and went back to their surgeon. The surgeon said, you know what, you might need more surgery. And then they took them and they put them in 2 groups. One group got more surgery and one group got spinal cord stimulation. Keep in mind, this was traditional stimulation. 50% of the time, 50% relief. We talked about that. In this study, what they found was getting more surgery did not help most patients. Getting a stimulator did. And so long story short, if you've already had a fusion, you still have pain, this is one of my first things that I talk to patients about.
Great. My second favorite question, have you worked with patients with CRPS?
Oh, I love treating patients with CRPS. I had 3 this week that were sent to me from several different states. I trained under a doctor named Gabor Rax, who was really famous as one of the doctors that helped define CRPS. And so I love treating patients with CRPS because we've had such good success and we have our entire protocol. But the bottom line is we do stimulation fairly early. If we're not getting good relief with lumbar sympathetic plexus blocks for the lower extremity or stellate ganglion blocks for the upper extremity, if we're not getting good success with neuropathic medications like Neurontin or Lyrica, we will rapidly move to stimulation, because what I have found is if you let CRPS linger 6 months, 9 months, 12 months, sometimes it becomes a lifelong malady that affects our patients. So I will do spinal cord stimulation and the data shows incredible results, to the point that sometimes the CRPS goes away and then we take the device out. And so yes, it works very, very well for CRPS, and it's pretty early in our algorithms to do spinal cord stimulation for CRPS.
Great. So this could be a little similar, but I guess it depends. But what about foot and ankle pain?
Yeah, for sure. I have a lot of podiatrists I work with, and they'll send me patients that I call end-stage foot disease. I made that up. That's not a real diagnosis, but they've seen a podiatrist and they've tried 2 or 3 or 4 different surgeries to entrap, you'll have entrapped nerves sometimes in your foot, and they'll do these surgeries to release them, and maybe they'll have done a fusion on the ankle, and then over time, the foot starts to change colors and it starts to hurt. And if you touch it, it hurts. And it's definitely on that kind of CRPS spectrum. And so I'll tell the podiatrist when they start seeing this, where they're getting worse and worse and worse, not better, send them to us. And spinal cord stimulation is one of the things that we do.
Great. Let's see.
We're doing pretty good. We're knocking through these.
Yeah,
we're up to 61 questions. Incredible.
I have disc issues. Will this help me until I get surgery?
Maybe. Disc issues is a big bucket. Once again, this is FDA approved for chronic pain of the trunk and limb, neuropathic pain of the trunk and limb. And so disc pain, discogenic pain can definitely be on that neuropathic pain spectrum. You'd want to see your doctor and make sure that he thinks it's something would be amenable. There was a big study presented at one of our big conferences just 2 months ago. We call it NANS, the Neuromodulation. It's like a North American Neuromodulation Society. And they presented data on virgin back. So this is backs that had not been operated on, just low back, and they did Nevro Hf10 stimulation and had incredible results. And a lot of that was probably discogenic. So I would talk to your doctor about your specific situation, but certainly disc pain leading to neuropathic type back pain would be treatable with Hf10.
Great. There's a couple of questions about the safety of Hf10 and potential side effects. Can you talk about that?
Yeah, I mean, when you talk about side effects, we've been doing this now between the trials and everything for probably over 10 years. When did you guys first launch your
we got FDA approval in 2015.
Got it. So 6 years in the US, but if you go back to in European trials and all that, we're probably looking at 10 years that they've been working with the therapy. And there's no long-term effects that we know of from Hf10. As far as putting it in, there's always procedural side effects. And so there's potential things like infection or bleeding or even nerve damage. But a well-trained doctor who's done a bunch of these, we just don't see that very often. Our single biggest complication is lead migration. And I mentioned that earlier, about 20% of the time, over time, the lead would migrate or fracture, and then the doctor would have to go back in and revise it. But we don't know of any real long-term complications from the therapy.
Great. So there's a question here about, would this work for pain related to arthritis of the mid-low back?
You know, it's not really approved for arthritic pain. It's more for nerve-based pain or neuropathic pain. Sometimes, you may think you have arthritis pain. It's really nerve-based pain. So that's where it's good to see a pain doc who can do a good assessment and say, you know what, I think some of this is neuropathic in origin.
Great. I'm going to butcher this one, but my pain is from, well, it's scar tissue adhesion pain, and scar tissue and adhesion pain. Might this help from the tightness, relief from the tightness, pressure, and pinching?
Can you tell from the question, is it spinal related, like scar tissue in the spine?
Yes.
Yeah, so scar tissue in the spine is typically from a previous surgery, and that is a slam dunk diagnosis of the original reason we did spinal cord stimulation. And so when you talk about scar tissue, it's usually grabbing and squeezing nerves, and this is basically what this was invented for.
Great. Question, how long do you have to keep this in your body?
Until you don't have pain anymore. So some patients, they get the therapy and then a year goes by and 2 years go by, their brain resets and they don't feel pain anymore. What I tell those patients is if they can turn their device off and 2, 3, 4 weeks go by and they still don't have pain, it's okay to take it out. We do that often with CRPS where we intervene quickly, we knock the disease down, and then we may take it out 6 months or a year later.
Great. Can you talk a little bit about, so does the trial procedure or the implant procedure require anesthesia?
Yeah, I usually give anesthesia for both. You're not in like I'm an anesthesiologist, and so I like answering questions about anesthesia. There's all sorts of ways to sedate people. For both the trial and the implant, it's not classic general anesthesia with a tube in your throat. We usually just put you to sleep, you take a nap, you breathe, through an oxygen mask, and you wake up and you have it. But we do sedation for both of them.
Great. So this is a great question. Just asking specifically, are the rechargeable batteries charged through the skin?
Yeah. Yeah, so we implant the permanent device under the skin, maybe 1 centimeter under the skin. And then at night or in the morning when you're drinking your coffee or whatever your routine is, you'll put an external device over it that charges it. But it's all just right through the skin.
Great. And this patient is asking, I had a stimulator removed during my second surgery. Can I get the new implant?
I'm sorry, would you repeat that question?
Yep. This patient had a prior stimulation device, and it has been removed. And can they get HF10?
Oh, for sure. That was on my slide earlier. One of the top 3 reasons that you might want to do this. Maybe you tried a stimulator in the past, it stopped working for you and you had to take it out. We know that's common because in the past, it was only 50% of the patients got 50% relief. And over time, that might have dropped to 30 or 40% that were still getting relief. So a lot of these patients have had it taken out. Some of these patients are coming back to me today. I actually had a patient last week that I put a stimulator in way back in 2007. And then over time, it stopped working. It was taken out maybe in 2013 or 14. They came back to me. I'm going to go back and try HF10 now.
Great. Is it safe to have the old stimulator leads, including the leads, removed and replaced with the Nevro device? So when are the leads replaced as well as the battery?
Yeah, I would talk to your doctor about it. There's so many different circumstances, but if you have electrodes in that work and they're already in the right spot, I like to leave them there because it's just easier to connect the new battery that drives the HF10 therapy. It's a smaller surgery and there's less chance of complication. But if, for example, it's 19 years old, or that question earlier, maybe it didn't work, or maybe the lead had fractured, or maybe, there's all sorts of reasons where you might take the entire system out and put an entirely new system in.
Great. So how does the trial work? Does it still require an incision and implanting the device?
No, the trial doesn't have an incision. It's all done through a needle. So I use the example of an epidural because we literally use an epidural needle, the same ones we use for pregnant women that are having babies. When we put in an epidural in the hospital, we go into the epidural space and then we thread a catheter. And that catheter, we infuse medication in. Spinal cord stimulation is the same thing. We go in that space and we thread an electrode, which is just like a catheter, and then you just tape it. So there's no incision. It's all done through 1 epidural needle or 2 epidural needles.
Great. Sai is asking an interesting question. Can this be used in both the cervical and lumbar at the same time? I have had fusions in both, along with pain in both areas.
It can, but you need a fairly progressive doctor who's going to fight with your insurance and get it approved. It's rarely done. Most of my patients, I'll start with one, see how they do, and then potentially come back and do the other. Theoretically, if you start in the cervical spine, you might actually get relief downstream on all the pain. So you'd want to talk to your doc about the best approach in that situation.
Great. How does HF10 compare to DRG?
That's a great question. So one of the companies, Abbott, has a new technology called Drg Stimulation, which is the dorsal root ganglion. And they got FDA approval specifically for CRPS and nerve-based pain in a specific dermatome. And so they were going after much more focal pain, like pain in the foot. They would go after L5 and S1. And so the way it's different is instead of putting it directly over the spinal cord, they're putting it over the nerve roots laterally. And even the nerve roots is slightly misstated. It's over a portion of the root called the dorsal root ganglion where the nuclei live. And so spinal cord stimulation through Nevro is put over the spinal cord, usually T8 or T9 thoracic spine, and dorsal root ganglion, depending on exactly where your pain is, they're going in at a very small level and identifying 1 or 2 dermatomes of pain.
Great. This is a great question, and I'm be curious to hear your answer. How do you decide if a patient needs leads or a paddle?
Oh my gosh, that's the $1 million question. We debate this a lot at our conferences, and it depends on, a lot of things. You can argue that the paddle, well, I shouldn't say you can argue, the paddle definitely is going to have less migration. The way the surgeons do the surgery, it's more stable. but the flip side is it's a bigger operation. And so it's like this, it's always the balance of minimally invasive. And so some doctors really like to do the paddle because they say it's less likely to move over time and it's more stable. Other doctors say, no, I'm trying to avoid a surgery for my patient. And so I'd much rather do this minimally invasive percutaneous approach. So I would really talk to your doc about their approach. And if you have a preference, you can always tell your doctor, hey, I really want a paddle. And most doctors will work with you to give you what you feel is best for you. They're going to coach you a little bit, make sure you understand the risk and benefits, but it tends to be a little bit patient specific.
Got it. Okay, well, this is kind of a similar question, is when do you decide to have an anesthesiologist do the implant versus a neurosurgeon?
Yeah, so same thing. So I'm an anesthesiologist, and I will do a percutaneous implant. So it'd be just like I'm doing an epidural in the hospital. I'll go in the epidural space and for the trial. When I come back for the implant, I do the same thing. I do an epidural, I go in the epidural space, I thread the electrode, but then I make an incision. So I turn into a surgeon, and I make an incision, a very small incision, maybe that big, and I put an anchor in, and then I put another little small incision, I put the battery in. So I do 2 small incisions, and I do it all what we call percutaneously. But sometimes you send it to a neurosurgeon or even an orthopedic spine surgeon who would go down and do a laminectomy or laminotomy in the thoracic spine and then thread the electrode in that way. So it's a little bit of a bigger surgery, but not a whole lot bigger.
Great. So I was asking an interesting question about the recovery process post the implant. Do people generally take off work? In particular, she's a nurse, or what is the limitations for during the process to scar over?
Yeah, once again, I would work with your surgeon, your doctor. It's gonna vary depending on if you're doing a laminectomy or a laminotomy or a percutaneous approach. But for my patients where I'm doing a percutaneous approach, I typically tell them they only need to take about a week off work. Take a week off. They're going to do probably sponge baths during that week because they've got an incision that we're trying not to get infected. Watch a bunch of Netflix, kind of relax, and then you can probably start to go back to work. Other docs I've heard say take up to 2 weeks off, which is, I think you should take as much time off work as you possibly can. So I'm kind of kidding, but usually a week is enough, maybe up to 2 weeks, but definitely, talk to your doc about what they think.
Great. I'm actually going to answer the next one, give you a second to take a deep breath. So this is asking, when is the next generation of this device and when is it coming out? So last year we launched Omnia, which is the device that offers the most versatility that Dr. Lynch spoke about. So it can offer a high frequency stimulation in addition to traditional stimulation. So that is the most advanced device available on the market now, and one that most physicians are offering. Okay. I have a Boston Scientific stim and it stopped working in 4 days. I believe that's the device, but have not been able to get relief. Is it too soon to change my device?
Yeah, I would say 4 days, I would be pushing really hard to get a hold of someone from the company or the doctor to reprogram it to see if the electrode disconnected, just to find out, in my practice, if it stops working, I'll usually do x-rays and see if it moved. I'll get with a rep and see if it's communicating. It could be as simple as the screw came loose. There's, it's technology. It's at the end of the day, if like my phone stopped working, I wouldn't just go get a new phone. I would go back to the store and be like, hey, fix this phone, And so 4 days in, you can work with a combination of the Boston rep and your doctor probably to get it working again. And then if not, if it literally just everything's functioning, it's in the right spot, and it doesn't give you pain relief, then you should talk to your doctor about other options.
Great. My third favorite question. King is asking, have firefighters had this placed and what were their results? So maybe you can talk about firefighters, military, police officers, and the difference between HF10 and other devices out there.
Yeah, it's for me, kind of a personal, question when you talk about firefighters. I was in New York City during 9/11, and I trained in New York from 2001 through 2006. So I saw lots of firefighters that would come in. There were a lot of injuries associated with 9/11 and guys that were down for hours at a time. We had patients that had sciatic pain because of injury. So we've helped a lot of military, firemen, police officers, people that serve our country who end up getting injuries. And, HF10 is one of my favorite go-to devices for any sort of back pain and leg pain or any kind of neuropathic pain that doesn't get better after, 6 months.
Got it. That's great. And one of the unique things about HF10 is that it doesn't, you can be programmed to not have the paresthesias. And because you don't have the paresthesia, it's one of the only approved devices for active duty military, police officers, and firefighters. So if you are in that line of work, it's especially an appropriate device.
Mhm.
Melinda's asking a great question. She's unfortunately got pain in the lower back, in the upper back, in the legs. Do you have to get multiple implants if you have multiple pain areas?
Most of the time, one thoracic placed implant is all you need. It covers everything kind of downstream from there. So low back, hips, pelvis, legs, and feet. There are some times where 2 implants would make sense, but typically it's just 1.
Okay, great. Shannon's asking a great question about how do you get a physician who doesn't currently offer HF10 to have a discussion about HF10? And, Shannon, I would say that doctors who are choosing to offer HF10 in their practice are specially trained and committed to using the device. So often it's very hard to get a physician that might not have that training in order to get up to speed to offer the device. So definitely would recommend speaking to your doctor, but also considering speaking to a doctor on the physician finder if you're feeling like you're not getting the answer you want. Dr. Lynch, do you have any, I'm sure you have a lot of experience with that and the different types of pain doctors. Do you want to add anything there?
Yeah, I think the only thing I would add is that we're living in a new age. I can remember 15 years ago, doctors would make fun of patients who went on the internet and read stuff and like, oh, you can't believe everything you read on the internet. But I love it when a patient comes to me from the internet and they've done their own research and they tell me what they want. Like, absolutely love it. I'll sit down and look at what they're looking at. I'll research it myself. Just in the last year, I've had patients teach me about 2 or 3 conditions I didn't even know existed until they showed it to me. And so I think you really want a doctor who is open-minded and willing to listen. And if they haven't currently trained on HF10 and you take the time and explain it to them and they still don't want to talk about it, then yeah, we get a second opinion because the science is squarely in the corner of HF10 therapy. So yeah, if they're not willing to talk about it, I would go to the hf10.com, look at the physician finder, find a doctor close to you that does it, and there probably is one within 5 miles.
Definitely great. Lots of questions about neuropathy. Is HF10 indicated for neuropathy?
Yeah, I mean, it's indicated for chronic neuropathic pain of the trunk and limb. So it's already indicated for neuropathy. There's lots of research studies going on right now to specifically look at things like diabetic peripheral neuropathy. And so I've been treating my patients for years that have neuropathic pain.
Great. How do you know where to place the leads on a first timer?
Yeah, it's really simple. We go at T8 and T9, and we basically, I'm sorry, top of 9, top of 10. And so there's a certain spot that we put right in the epidural space, and that's where they did it during the research study. And so for years and years, doctors debated, was it 8, was it 9, was it 10? During the SENZA trial, they put it in a very specific spot, and they put it there just like the research study.
Great. Here's a good one. My pain is positional, not constant. Would this help me?
Positional, not constant. It would depend. I'd want to talk to that person a little bit more and kind of understand. But certainly, many patients don't hurt 24 hours a day, 7 days a week. There's certain things when they're standing or when they're sitting for a long time. But if it's true, serious neuropathic pain that's severe and has lasted a long time, then yeah, it probably makes sense.
Great. Is there a risk of further back damage when getting HF10?
There's always risk. I mean, I tell patients when we're doing these things, whether it's an epidural or going to the chiropractor, there's risk and benefits of everything we do. And so, the big risk that I always disclose is the number one most common risk is migration that we would have to go revise again. Number 2 is probably infection, where you could get an infection that would need to be treated. But there are even, much more rare risks with things like nerve damage. And so there's always risks of that, but it's fairly uncommon.
Great. Let's see. This poor patient has tried injections, radiofrequency ablations, spine fusions. They've tried everything and nothing has worked. Could HF10 potentially help them?
Yeah, for sure. I mean, those patients with the new studies coming out showing how well this works for low back and even low back that's for virgin backs, we're doing more stimulation just for low back pain. If they've tried everything else, this is probably the next step.
Great. I'll be curious to get your perspective on this. Patrick's answering, my wife had CRPS in her right foot for nearly 12 years. Her Boston Scientific stimulator has helped, but certainly not made it go away. She tested DRG and it worked, but insurance wouldn't cover a permanent replacement.
Huh.
Have you found insurance companies improving HF10 differently than DRG?
Yes, because it's over the spinal cord. And so I think we have higher success rate with HF10 than we do DRG. It's unfortunate when something works so well and insurance doesn't want to cover it.
Yes, Dr. Lynch, that's been our experience as well. We've seen that same nationally, that DRG is often hard to get approved, but HF10, because of the evidence and the placement, it does tend to get approved more readily.
And I'm just going to answer one of these because I'm looking through the questions at the same time as you. I've said CRPS like 3 or 4 times, but I never explained. I hate it when doctors use jargon and we don't know what they're talking about. So it's complex regional pain syndrome. It used to be called RSD, or reflex sympathetic dystrophy, but it's when you have an injury, sometimes just a minor injury, sometimes more major, but then either your foot or hand or an area will turn red and it will swell and there'll be temperature changes and it hurts to the touch. That CRPS, or complex regional pain syndrome, is much more common than people realize, and it's treated really well with spinal cord stimulation, and specifically HF10.
Wonderful. Thank you for answering that acronym question. Sandra's asking if she could run after it. So do people get back to running, riding bikes, riding horses, playing golf?
For sure. I tell them give it a couple of weeks to kind of scar in, and then they can get back to a normal life.
Great. So Ellen's asking, if a patient been on different medications for years, has stenosis, neuropathy, damage, 17 years of all of this, is it possible to reduce drugs and be able to hear from, be able to get relief from the pain with HF10?
Yeah, for sure. I mean, just think about the concept of 80% pain relief. If your pain was 80% decrease, how much medication would you need? And what we find with most patients, they don't all come completely off meds, but they almost all across the board reduce their doses. And some of them come off completely.
Great. Let's see. Could you talk about the battery life for HF10 and when does HF10 need to be replaced?
Yeah, we don't know exactly, but over 10 years. And in our practice, the batteries just aren't running out. We're at like 6 years now and they're still going. It was approved for 10 years and we think it's going to actually be longer than that.
Great. Could you talk about MRI compatibility? Can people still get an MRI if they have HF10?
Yeah, they can. And I forget the exact conditions, and so I'm sorry, but we can follow back up with that person. It's conditionally approved for MRI, which means there are certain things that you have to meet, but it's for the whole body. And so we just need to follow up on, is it 1.5 Tesla whole body, or do you remember that? Say it again.
I think it's 1.4.
1.4. Okay. Well, why don't we follow up? There are some conditions, but the bottom line is it's very easy for you to get an MRI, but you still need to disclose that you have a stimulator and then work with them to make sure they do the right protocol for the MRI.
Great. Thank you. Great question. My pain doctor is requiring a psych evaluation before proceeding. What is the purpose of the psych evaluation?
The purpose is for insurance to slow you down so that they don't have to spend so much money. If insurance, if they can delay you a couple months, maybe you'll switch insurances or switch jobs. I forgot the exact number, but 39% of Americans switch jobs every year. That's a real number, 39%. And I think it's around the same number that switch insurances every year. And so a lot of times insurances just do things to delay that don't make sense. The original theory on psychological assessments was, well, maybe these patients, their pain is better described by some psychological phenomenon. That's almost never the case. I mean, a good pain doctor knows if someone's pain is better described by a psychological phenomenon. It's become just kind of a hurdle that we've got used to in the industry. It's required by all major insurances and we do it, but mostly it doesn't make sense to me.
Great. Another question, just as we're wrapping up here, is about the restrictions during the trial. Do you have any special tips for people to minimize the restrictions? One, for example, that I see patients is to get a grabber, for example, so they can still reach stuff without having to bend or twist too much. But any specific tips you give people?
That's a good one, by the way. I love the grabber tip. I don't know. I wish I had better tips for patients. Most of the time, over like a 3 to 7 day period, we don't have migration. It's the longer periods of time where we get migration. I had a patient a few years ago who got in a massage chair during his trial, and it thumped the electrode all the way up to his neck because it was vibration. So I do tell patients, don't get in a massage chair. But some of my tips have just been experienced over time on things they did wrong. Long story short, you want to take it easy for like a week so that it doesn't move, so that you get the best chance to see if you have pain relief. You don't have to completely stop living. You can go for walks, you can do stuff, but I wouldn't go play golf, and I wouldn't get in a massage chair, and the grabber idea is really good. And so just things to kind of minimize bending, twisting, and things that would lead to migration.
Great. Well, we've been able to answer most of the questions today. I think we've got a couple more still coming in, but I do want to respect everybody's time. So let's see if we can go to the next slide, Stephen. So we did try our best to answer all your questions today, but we know we couldn't get to everybody. So if you would like to have a one-on-one conversation with a patient education coach, again, you can call 800-387-2381, and coaches are available to take your calls from 6 to 5 p.m. Now, I did see a couple of patients here who had specific questions who actually have HF10, and you will call the same number and get connected up with your local care team. It's getting you the best care and support, and people who know your particular situation is really important to us, because we just don't want to give you a generic, answer, but really want to know your medical history. So if you are having any issues with your device or charging, it's best to call your patient education coach and your local care team, and they will be able to answer your questions. And they're also there to answer questions from prospective patients. It's an exclusive benefit of signing up for these webinars. We really want you to get your questions answered. So next slide, please. Okay, that just our disclosure. So Dr. Lynch, thank you so much for taking the time today to speak with all of the patients, to answer the questions through the lightning round. Your wisdom and experience, especially the one about the massage chair, that's a new one to me. We'll add that onto our things to not do during the trial. But just thank you so much for your time and sharing your experience with HF10 with more patients.
Yeah, for sure. And I think you said this earlier, but this video will be up on your all's website, so that is it on your hf10.com website they can see it, or right, YouTube?
Yeah, so it'll be up on both. We'll have it up on YouTube shortly. That'll be the quickest way to get it, but we'll also send it out to everybody's email inbox as well.
I'm going to put it up on my Facebook tonight for some of my friends that are really interested in this stuff. I think this was a good time to be able to talk about this. And I want to thank all the patients that logged on. What a great group of patients tonight, and wonderful questions. I appreciate you guys joining, and I really hope that you can find pain relief.
Wonderful. Well, thank you so much. And thank you to everybody who joined us, and have a great night. And we'll be doing these once a month. So if you enjoyed this and you have more questions as well, we'll come back next month. So stay tuned to your inbox for another invite. Thank you.
Have a great night. Bye-bye, everyone.
Bye.
Bye.